This episode of Senior Moments is sponsored by Assist Care Senior Living, providing exceptional care for seniors for over 30 years. Located in Amador County, contact Fleta Herndon at 209-257-1377 for more information or to schedule a tour. Welcome to Senior Moments, the podcast where we discuss all things senior, the good, the bad, and the utterly ridiculous. Today I have with me Thomas Johnson from Hospice of Amador and Calaveras. Welcome.
Thank you. I appreciate your invitation.
Oh, I'm so glad to have you here. I haven't heard anything from Hospice for a while. I used to go to the Commission on Aging. We were just talking about that in Amador County, and since I have not been there in about 18 months, I'm out of the loop with Hospice. So.
Well, I'm here to clear that loop.
Thank you. So you want to tell us just a little bit about yourself and what your role in Hospice is?
Yeah, definitely. My name is, like you said, is Thomas Johnson. I'm an LVN, a licensed vocational nurse. I work for Hospice of Amador Calaveras as a clinical support and an intake specialist. So I do referrals, I take referrals and assist people in coming onto hospice and triage, say people who are on hospice call in for assistance, medication assistance, things like that. And I triage over the phone.
Okay.
Yeah, and go out if necessary to visits.
Do you do most of your work over the phone then, or is it kind of how?
Most of my work is over the phone or online.
Okay.
Yeah.
And has that happened since COVID, or has that always been the way?
My role, it's always kind of been like that. Yeah,
okay.
Definitely. But COVID, we did have a shutdown of like nurses not coming into the building and kind of prevent the office staff and field staff from mingling, kind of preventing that possible cross contamination and things like that.
That makes sense.
Because if the whole building got it, then it wouldn't be good.
No, it would not be good. It's never good when a whole building gets something.
Right.
I do know that for a while my bank here in town was closed because they only had one person, so they had the drive-up window open, and I felt so bad for that one person there all by themselves. They did what they had to do. They couldn't have them all sitting in there sick. So
absolutely.
Yeah, it was an interesting time. Yes. So let's talk about hospice. What services do you provide?
Well, let's start with criteria. To be eligible for hospice services, you deemed by a medical doctor, medical prognosis of 6 months or less.
Okay.
And that means, a terminal diagnosis. And so the services we would provide for somebody with that prognosis would be nursing services. That goes from anywhere between a nurse, an RN case manager managing your case.
Okay.
Nursing visits anywhere from 1 day a week to 7 days a week, just depending on what the case manager feels. Home health aid services. These are CNAs and home health aides who come to the home or wherever you're at.
All right.
And provide activities of daily living services. Bathing, showering, assistance with dressing, teeth brushing, hair brushing, things like that. Linen changes, and just in general, just some good companionship during that time.
Okay.
We also have social worker. Our social worker is calling Brazil, and she basically manages that social dynamic of things, FMLA paperwork, getting your affairs in order, things like that, among other things. She'd be able to describe that a little better, but just somebody in your corner that, outside of your physical illness, how do you manage your life during that time?
Right.
Assisting with your questions and with facilitating access to paperwork and other different things like that.
Okay.
Bereavement or chaplain services. Tim Johnson is our chaplain now, and that's a spiritual or religious or any kind of, again, companionship and really just kind of trying to tackle the different dynamics that involve a human being. Physical, psychological, spiritual, those things. And then we offer volunteer services. So we have volunteers that would be able to go into the home, again, not providing those physical services like caregiving, pericare, things like that, or administration of medications, but maybe some simple meal prep, book reading, companionship, conversation, things like that.
Sure.
We provide access to it's called DME, durable medical equipment. It's
Okay.
things like hospital bed, shower chair, bedside commode, over bed table, anything that is going to help you live your life.
All right. So after I pass away, then you can take all that equipment back.
Absolutely.
Okay.
Absolutely. Most of the time, it's done next day or same day, or at a day in which, because oftentimes, let's say, it's a family member that's coming in from their home to help their loved one. Let's say, oh, well, we can't, I won't be there for a week, because somebody has to be there to receive and then release the equipment.
Okay.
Our company, Horizon Oxygen, doesn't walk into people's homes without people present.
That's good.
Yeah, definitely.
I don't think I want you walking into my house when I'm not there. So I have to say, I have a friend in Jackson that used your services, and it was really impressive. Her husband was at an assisted living facility, and he wanted to die at home, and it was clear he was getting close to the end of his life. So hospice came in, and holy smokes, they were on top of it. The bed arrived, the equipment arrived, everything got there before he got back home, and it was a well-organized, well-oiled machine, I have to say.
Yeah, there was a process, and given during certain times of the day, we can get in there and get everything prepared within hours.
That's
it just
amazing.
depends.
Yeah. Okay, so let's go through a scenario. I am a cancer patient. My doctor has told me that I have 5.5 months to live. All right, I shouldn't be flippant about that. Let's just say I've got 5 months to live. So do I contact hospice at that point, or does my doctor contact you?
It works many ways. In my experience, I have had people say my doctor told me to call you guys.
Okay.
I do receive referrals from doctors. I've had doctors personally call. Usually it's their medical assistants or other staff. And oftentimes it's family members.
Okay.
It can work anyway.
All right.
A referral from an MD is the best way.
All right. So now that you've got the referral, what happens next?
Well, with the referral, there's hopefully medical records attached to that, so we can validate that the prognosis is there, that this patient exists medically, and that we review those records with our medical director, Donald Van Fossen. He likes to be aware of all admissions, and he will give the blessing and say yes or no, or it's an evaluation.
Okay.
Most evaluations strive off of the diagnosis of Alzheimer's, or something like what's called failure to thrive, severe protein calorie malnutrition, where there's no real disease, but there's just not that thrivingness, weight loss, maybe a little cognition decline, things like that. And so we'll send a nurse in to do that evaluation, gather that data, and then while we're in the home, that nurse will call our medical director, Donald Van Fossen, and have that conversation right there in the home.
Oh, that's good.
Yeah, and so if the determination is the prognosis is 6 months or less, which Dr. Van Fossen can do, he will then give permission to admit to hospice, and the admission will take place right then and there.
Okay. And then what happens? Do I never see my original physician again? Let's say I hear a lot of things like, you can't go to your doctor anymore, you can't do this, you can't do that. If I get a UTI, do I get to have some penicillin to take care of it, or whatever the doctor may order?
Those are
how does that work?
Common questions. And so what happens, and a lot of it has to do with billing.
Okay.
Right, and so you're more than happy to contact your doctor as much as you want. We're not here as hospice, we're not there to tell people what to do.
Okay.
We're there to advise, support, educate, things like that, collaborate. So when it comes to seeing your primary care physician, generally what it would be maybe like a checkup, not related to the primary diagnosis. And that's where it kind of gets tricky as to, is that doctor going to bill that visit? Or is it just a friendly conversation over the telephone?
Okay.
Right, and so if it's going to be a billed visit based off of, let's say, Alzheimer's, and they're going to kind of go over medications, cognition, decline, and maybe order certain medications for that wouldn't be covered by Medicare because that person elected their benefit of Medicare to switch to hospice at the time.
Okay.
But that only covers that primary diagnosis. Let's say you have some skin issues and you'd like to see a dermatologist or your primary care for that to get a referral for that. Absolutely, you can because it's not related to the primary diagnosis.
Okay.
And so Medicare should continue to cover that.
All right.
Absolutely. And then what was the second part of that you mentioned? It was seeing your doctor for treatment of UTIs and things.
Yeah.
So urinary tract infections can occur mostly in the elderly due to their disease, their anatomy, things like that, and it can be uncomfortable. We will provide comfort in the form of antibiotics, let's just say in general, education on how to prevent future UTIs by educating the caregivers on, let's say, proper cleaning practices, things like that, washing the patient's hands prior to meals, because somebody who's not really cognizant and able to, like with the Alzheimer's diagnosis, unable to really, grasp the cross-contamination aspect of that, it's our job to make people aware, how those things can happen and how to prevent them.
Oh, that sounds like a really good idea.
Yeah, definitely, definitely. And it's a wonder to see after that education and sometimes repeated education, how those issues reduce.
Oh, absolutely. I read something, and I'm not going to tell you which president, one of the presidents that was shot in the early days, but I read an article that basically claimed if his doctor had washed his hands, the president would have lived, but because he stuck his hands in this bullet wound that were full of junk, infected the wound, and bye-bye president.
Yeah, there's so many variables when it comes to triaging, something like that, or care, basic care, how you introduce, me as a nurse when I come into the home, practicing hand washing prior to connecting with the patient, and then hand washing after, because our hands are everywhere, touch everything, and it's just amazing how a simple hand washing.
It is amazing. As I've gotten older, I'm really cognizant of washing my hands before I touch my eyes, because I absolutely don't want to get something in my eyes that is going to hurt my vision, which, it's already a challenge. As I'm getting older, it's getting more challenging. So, I don't want to hurry that process along. So I'm pretty well aware of what I'm doing. I would hope after COVID we all know how to wash our hands.
Yeah. Like I was saying, hand washing, it's one of the means of transmission is touch, right? And so hand washing is just a blessing. If everybody did it, there would be a lot less contraction of disease.
That sounds like a good piece of advice. So we were talking a little bit about palliative care when I spoke to you yesterday, and I guess I'm not completely clear on where does palliative care stop and hospice care start?
Okay. Of course, my forte is hospice. I haven't worked for a palliative care organization or an organization that provides that palliative care.
Okay.
There is an agency out here, I won't name them, but the program's called AIM, AIM.
All right.
And I believe it's called Advanced Illness Management. And where that, to my understanding, there's that fine line that says, I have this disease. I'm not yet terminal, but the symptoms I'm experiencing are advanced.
Okay.
And I don't want to go to the hospital all the time just to get comfortable again. And so what palliative care would do would be able to provide you the skills, the knowledge, the tools to be able to manage that illness at home.
Okay.
And of course, everything is a decision that we make, right? Informed consent is one of the very strong philosophies we hold in the medical industry. Making sure that that person understands what's going on, what the options are, and that they know it's their decision. It's everybody's decision who they want as their primary care physician, but that primary care physician has to accept. It's everybody's decision if they want to go on palliative care or if they want to go on hospice. And so education, I think, is that important part. So let's say, let's take a disease, for instance, congestive heart failure.
Okay.
Right, so congestive heart failure is where the heart's just not working properly. It's not able to do its job, and you're experiencing symptoms like shortness of breath, fluid retention, just to name a couple. And those can really hamper your ability to perform your ADLs, your activities of daily living, like walking to the bathroom. It's a simple thing of getting out of bed. And just to give you an idea, somebody who is still able to, without extreme, severe distress, do those activities, but they still can have those symptoms, would be more palliative appropriate, as opposed to somebody who is just unable to get out of bed. Somebody, we call people, we say bed to chair existence, where even if you, literally from your bed to your chair, you can't walk really, even eating causes shortness of breath, speaking causes shortness of breath, and the difference between the two, I think, would be somebody who's choosing to still manage that care and have the choice to go to the hospital related to that care.
Right.
And still receive palliative care when they come out without ever losing that palliative care access. Let's say somebody who is on hospice with the congestive heart failure, if they choose to go to the hospital for reasons related to that diagnosis, they would have to do with something, it's called revoking from hospice, or discharging, one of those two terms. And revoking is the choice of the patient. Discharge is an agency decision.
Okay.
And so that's kind of like the difference between the two. It's always a choice, but what access do you want? Healthcare, ER, different things like that.
Sure, that makes sense. We talked a little bit about hospice scams. We had Karen Townley came on from HiCap the other day, and she was talking about hospice scams. And have you run into that, where people have been talked into going on hospice when they weren't actually ready for hospice, and then you hear stories, but I'm not going to speak of them because I can't validate them, right? Because it's hearsay, right? But I was looking into something, and it's called Senior Medicare Patrol. Oh, she brought that up too. That sounds like a good organization. Yeah, so they're nationwide. Every state has their own branch, and they are the agency that you can report things to. Like, let's say, for instance, here's, I was reading a possible scam where somebody comes into your home and convinces you to come on to hospice. They may use the services provided as enticement, etc., where that patient's not actually hospice appropriate. They don't fit the criteria yet. There's other scams, like I was also reading that healthcare providers are getting their identities stolen. However they use that, that's an issue too. All right, and so the Senior Medicare Patrol advises to protect your Medicare number. Don't speak to strangers about your healthcare conditions and things like that. Sometimes you may be walking, in the store, and you just bump into somebody and they just have a gentle conversation, and it leads to your healthcare. Wow, that sounds great. And then all of a sudden you're not getting what you thought you were, but your name is attached to billing to Medicare. Oh, that's great. Yeah. So there are scams out there. When in doubt, you can always call the Senior Medicare Patrol. I did not bring the telephone number with me, but just type in seniormedicarepatrol.org or .com, and the website that I was looking at had the number down there at the bottom. Yeah. So in addition to the care for the actual hospice person, the patient, and you do call them patients? Are they patients or you call
They
them?
are patients technically, but they're humans.
Okay.
They're people.
Well, sometimes I only ask
Yeah.
because sometimes organizations will refer to someone as a client or
Yes,
they
yes.
have a
We call them
preferred.
patients.
Okay.
Yeah.
So you have a patient, and do you offer other services for like the family members and other things other than the care itself?
So, we treat the patient as a human being, as the center, right? And then imagine everybody around them as a spoke,
Okay.
right? And so the family's real close to that center. And so we do help the family as well while they're on hospice. But then let's say that the patient passes away due to their disease. We interact with the family for up to a year afterwards and more if needed. Bereavement services, grief. Let's say there's a child in the home that is exposed to this process, and the family would like some kind of grief support. We call it Grief Busters program. It's for children.
Okay.
And now we've also established a program for almost every single age group, young kids, young adults, things like that. And so if there's any questions about that or you need those services, give us a call at Hospice. And you don't need to be a hospice patient to inquire about our bereavement services.
All right.
We take it seriously that there's grief out there.
There is definitely, and I think having the different age groups separated out, it makes a lot of sense to me. I think that we process grief differently as we age, and the age, being able to relate to someone else your own age in that group, I believe would be very beneficial.
Absolutely, absolutely. I think call us, of course, to get more data. That's not my scope, but I do
Right.
know of that it exists. But there are in-person and then telephone call interaction with that grief process and then that bereavement process.
Okay.
So I know we hold every Tuesday, I think at 10 o'clock at the Senior Center in Amador County, we hold the in-person grief group.
Okay. And is that a general, everybody can come one, or is that, okay.
Yeah.
And do you tend to go to the schools and have somebody, do you have
We do
grief
have
busters
somebody,
at schools?
yes, we do, yeah. Especially when there's like that unfortunate event of like, somebody over the weekend or during the week or whenever,
yeah.
Driving and, death happens.
It does.
Yeah, we have our Grief Busters organizer go to the school personally.
Oh, that's good. That's really good support to have.
Of course, it has to be asked for. We don't just go there and,
Sure.
hand out pamphlets for Grief Busters, but
I'm sure the schools have a good enough relationship with
Absolutely.
you that when something like that happens, the first thing they do is pick up the phone. So,
Absolutely.
yeah, that's a good thing. And that's a really nice thing about having an organization that's local here in Amador and Calaveras County, is that you are able to tie into the community so much better than if you were out of the county and, say, some big corporation.
Absolutely.
Yeah. So that kind of brings me to my other question is, what is the difference between a nonprofit hospice and a for-profit hospice company?
Well, okay. So the main distinction is going to be that we don't charge anything for any of our services, no matter what health insurance or ability to pay.
Okay,
We are absolutely free.
good to know.
One of the years, I think it was a year, 2 or 3 ago, we provided over $50,000 worth of services to the community for free.
Oh, that is an amazing achievement.
So
So thank you very much
Yeah,
for your contribution to our
absolutely,
community.
absolutely. So some people may have insurance, but that insurance doesn't provide payment for hospice.
Okay,
So that happens as well.
all right.
So we don't turn you away. We take you on.
All right, and then what if I'm in an assisted living facility? Do you work with the assisted living
We do.
facilities?
We do.
Okay,
Yeah, we have a very strong relationship with our local RCFs.
okay.
Absolutely.
And do they then, so how does that process work? Would the community or the facility call you, or does their resident call you, their resident doctor. I mean, it starts to get a little convoluted. Now you got a whole other entity kind of
Absolutely.
mix.
But we treat it all the same, like I was saying before. It could
Okay.
be the patient that calls. I just got this new diagnosis. Awesome. Let's inform your primary care that you're choosing this, unless they've already talked to you and told you to call us.
Right.
I'll get referrals from the caregivers, the administration of the care team saying, we think this may be good, so then we'll start the process by informing the primary care physician, which with something that's called an attending physician's agreement.
Okay.
So it asks how they'd like to participate, who we got the referral from, and what they would like to do. And I could get a referral off the street and I would investigate it and go forward with it. And it pans out. If they're not appropriate, they're not appropriate.
Well, I'm glad you involved the primary care physician in that whole decision process.
Absolutely.
I think that's really important. I think that having a fuller conversation with more people in it right in the beginning can solve a lot of issues or prevent a lot of issues from coming up later on if you just kind of jump into things without really digging in and make sure everything's
Well, it's
how it
respect.
should be. I think that's a very good word.
Respecting the community is not just the populace, the people.
Right.
Respecting the administrators, respecting the physicians. These are their patients for possibly decades,
Right.
and they know them really well. And it has happened where I've received a referral, and they may have been appropriate or may not have been appropriate based off of the interview over the phone, but informing those physicians, the primary care physicians, they have the opportunity to have that in-depth conversation and continue that relationship, which they'd like to continue. It's a very sacred relationship.
Oh, that is good to know.
Mhm.
Yeah. So, I had something else I wanted to ask you about. I have no idea what it was now, though.
Something that's come up a lot is the understanding what pulsts are.
Oh, thank you.
Yeah.
Yes, let's talk about polls.
Definitely. A pulst is a pink card, right? It's a card, you can get it anywhere, any of your doctors, they all have it. It stands for, PULST is an acronym for Physician's Order for Life-Sustaining Treatment.
Okay.
So it kind of details how you would like, if you were found on the street or found, let's say in your bed, somebody calls 911 and you have a pulse hanging on your fridge or above your bed or something like that, it details how those emergency responders are supposed to interact with you.
Okay.
Right? Let's say that, and just to kind of veer slightly, people on hospice can be full code.
Okay.
Right, that's an important distinction.
And what do you call full code?
Full code means that all life-saving measures are to be enacted.
Okay.
And so it goes full code, and then it goes limited interventions, and then DNR, which is do not resuscitate.
Okay.
And so hospice patients have had that full code, and we advise to call 911 and start compressions if they know how to.
Okay.
We jet out there and we do what's right.
I think that's a big thing with the pulse. And again, I thought I understood pulsed, but what I'm finding out is there's a lot more nuances to it than I understood. So I am of the belief there's probably a lot of other people out there like I am thinking that pulsed was either have them do compressions or you don't, and you don't have a lot of choices in between, you either try to save them or you don't, but it's good to know that there's actually steps in between and you don't have to go.
There's limited trial periods of G tubes for feeding,
Okay.
etc., or IV antibiotics, IV fluids, etc. You can pick and choose what you want.
Okay. And then the other thing that I'm curious about, have you as hospice worked with people that have chosen to have a death with dignity? And I don't remember the bill number.
The End of Life Option Act.
Thank you. End
Yes.
of Life Option Act.
Mhm.
Have
And-
you worked with people like that?
Absolutely, yeah.
Okay.
Sometimes people come with the referral to hospice with that already in place with their primary care physician or physician of choice.
Okay.
And sometimes we would advise them of their options.
All right.
Couldn't tell you how many people say, I just want this to end. Well, okay. Let me refer you to my social worker who can help you, gather more information about that.
Okay.
And so what would happen is that information would be shared, informed consent,
Yes.
things like that. And then let's say they choose, I would like to go forward with this, and they ask, how do we do this? We can help by sending a referral out.
Okay.
We don't do that. We don't order the meds. We don't create the orders, the care plans, things like that for that. We would refer to UCD or Sutter, and they would choose or assign a doctor to move forward with that.
Okay.
You have to be of sound mind to elect that. There are 2 doctor face-to-face visits that are required prior to assess for that.
Okay.
And then an outside pharmacy, not our pharmacy, an outside pharmacy, once all that process is taken care of, would then deliver the medications to the home with instructions.
Okay. And then when you say UCD, you're talking UC Davis?
UC Davis, yes, sorry.
Okay.
Yeah.
No, that's fine. So 2 physicians, and it's my understanding you can't have a family member in there when you are talking to the physician.
That may be true, to prevent alterations of information.
Right.
Cueing them to say this or say that.
Exactly.
That may
So
be,
you can't have a relative in there that, I don't have anything to leave anybody, so I don't have to worry about this, but if I did have a lot of money, I could have a sibling or a child in there going, well, you don't want to live any longer.
holding cue cards.
Yes. This is how you respond. Yeah, so I think that.
That sounds fair and logical. I do not have any exact knowledge as to if that is true.
Okay.
You can always call us, and I can always refer to Colleen Brazil,
Okay.
our social worker, who is a wealth of knowledge with myriads of things.
All right.
Yeah.
So let's say we did all that and I got the meds delivered to my house. Will hospice come out and monitor make sure that I'm actually following the directions for the meds? So
No.
after that, you're just kind of on your
Yeah.
own?
Our policy is to not be involved in that.
Okay.
We will support the family. We step out during that time,
Okay.
and then we come back in once it's done.
That makes sense to me.
Mm-hmm.
So we're about out of time. So is there anything we haven't covered today you think we ought to cover?
Well, I'd like to just kind of encourage people that if they have any questions or if they're in doubt, or like I was saying before, if they haven't seen their doctor in so many years, but and they can't get out of bed.
Right.
They can't go to their primary care physician or things like that, to give us a call, and that happens often. And there's a process, there's steps to kind of take, and I can help with that, or any of the other intake people at hospice. It's challenging when you're in pain to think clearly. It's challenging when you've not navigated the healthcare system in a long time, and now you are needing help. And so one of the things that we've done is people, I can't get out of bed, my mother can't get out of bed, there's just too much pain. Okay, who's their primary care physician? Oh, well, we don't have one. Okay, well, where have they been seen before in the past? And then they tell us.
Okay.
And then, let's say there's no medical records, ever, nothing. Dr. Van Fossen is a neurologist, and we can take a nurse and a phone and FaceTime Dr. Van Fossen with the patient.
Nice.
And he can diagnose right there.
Oh, that is a wonderful.
And if they're found to be appropriate, we can move forward with that process.
Okay.
It's one of the things that is unique to the rural area because of the nature of it. So far away, people like their seclusion.
That is true. That is true. I think telehealth is a big boon
Huge.
for this community.
Mm-hmm, absolutely.
Yeah, I love telehealth. I can call and I can have a prescription called into the pharmacy in town, and I can go get that and spend less time with all of that, including going and getting the prescription, than I'd still be sitting in the waiting room.
Mm-hmm.
So yeah, big proponent
I
of.
love it. I used to live in a place where there wasn't any internet, so I'd have to just drive down the road and in my car have my telehealth visit just right there in the car. So
that's
yeah,
funny.
it's a unique, wonderful opportunity for physicians to maintain that visual contact with their patients.
It is, and especially in rural communities where it's so hard to get medical care anyway. It's just really been a big boon for us. All right, well, why don't you tell everybody how they can contact you? Give us your phone number.
So we are Hospice of Calaveras, Amadore and Calaveras.
Okay.
And our telephone number is area code 209-223-5500.
Okay.
You can find us at hospiceofamador.org.
Okay.
And just give us a call.
Absolutely.
Yeah,
this has really been informative today. I'm so glad you came down and talked to us. So yes, I encourage everybody, give hospice a call if you're in that situation. And if you have questions about hospice, please give them a call. They're happy to talk to you. And we don't want anybody out there suffering if they don't have to be.
Definitely.
So, it's a good thing.
If I may.
Yes.
So we are, as I was saying, we are a nonprofit organization, and we do rely on Medicare, billing Medicare, et cetera, but also we have thrift stores. We have one in Angels Camp, and we have one in Jackson, in Amador County. And we also, if you'd like to support what we do, we have an art auction September 8th.
Okay.
And tickets are still available. And just in general, donations. If you'd like to just donate anything, please just contact our office or go to hospiceofamador.org, and all that access to that information is there.
Wonderful. All right. Well, thank you for coming on today.
Absolutely.
And thank you all you podcasters for listening with us today, and I hope to have you join us again on the next podcast. This episode of Senior Moments is sponsored by AssistCare Senior Living, providing exceptional care for seniors for over 30 years. Located in Amador County, contact Fleta Herndon at 209-257-1377 for more information or to schedule a tour.